I'm here with Dr. Zemel, Chief of Pediatric Rheumatology at CCMC. Dr. Zemel, I know rheumatology encompasses autoimmune diseases. What else does this rheumatology deal with?
About half of the kids have autoimmune disease, and the other half will have what we consider non-inflammatory disease, like chronic pain syndromes, fibromyalgia, chronic fatigue syndrome, kids who are loose-jointed, who have chronic pain. We also deal with Lyme disease as well, which is has some autoimmune components, but is basically an infectious disease.
From what I've researched, I understand there are many causes, including genetics, environmental triggers, and hormones. What do you think, or what is the scientific consensus on the causes of autoimmune diseases?
Well, that's a tough question, and different diseases may have some different causes, but you're right. I mean, we feel that there probably is a genetic predisposition, that is, children may have a certain set of gene variations, mutations, or what are called polymorphisms that make them at risk for autoimmunity, and then it will take some other trigger, like an environmental trigger, a virus, Epstein-Barr virus, the monovirus, sunlight, some other illness that can then trigger autoimmunity that goes from kind of silent, what we call subclinical, and then it becomes more evident clinically.
As a pediatric rheumatologist, do you notice that children are more affected? Do you think this age group is more vulnerable to autoimmune diseases?
You mean compared to adults?
Yeah.
No.
No.
No, I think autoimmunity tends to affect mostly young and middle-aged adults. So for lupus, for example, which is the prototype for an autoimmune disease, the typical target population would be women from 20 to 40, roughly. 10% of lupus starts in childhood. So the majority of patients with lupus start during adulthood.
So do you see that, everything I read said that women are more likely. Do you see that in your office?
Sure. And, well, for lupus especially, the ratio in adults is roughly 9 to 1, women to men. It's probably about 7 or 8 to 1 in kids, that is, girls to boys, although the younger the age group, the less hormones play a role. So we don't really see very much lupus between 5 and 10, but in that age group, the gender differences are not as striking. There are other autoimmune diseases where the female to male ratio is different. So, for example, there's a condition referred to as ankylosing spondylitis or spondyloarthritis, which is another autoimmune disease, and there actually men are more affected than women.
What is the process of being diagnosed with autoimmune disease? It requires a referral from a primary care doctor, and then they come to you?
Yeah, so typically what happens is a child will be having joint pain, unexplained fever, unexplained rashes, or there may be some other symptoms that bring them to the pediatrician, and the pediatrician decides, either based on the exam or based on some lab studies, some preliminary lab work, they would then refer. So virtually all of our patients are referred from either a primary care doctor or from an orthopedic doctor.
Does your office work closely with like neurology or like therapists too, or is it?
When you say therapists, you mean mental health therapists or physical therapists?
Like physical therapists to kind of help with the pain and.
Yes. Well, if I mentioned that maybe half of our kids will have chronic pain issues, and in those cases we do a lot of physical therapy, and we have a pain service here, a comprehensive pain team, and so we work closely with the pain team. So we don't work so much with neurology for pain. We'll use neurology, if one of our patients has involvement of the central nervous system, the brain or the spinal cord, or the peripheral nervous system, the nerves, and then we work closely with neurology, and we team up with most of the other divisions in this hospital, depending on what other organs are involved.
One of my chapters is on polyautoimmunity. Do you ever see that a patient diagnosed with one autoimmune disease tends to have other ones as well?
Yeah, you are more at risk for other autoimmune diseases. So, for example, a common combination might be diabetes and celiac disease. Although, I don't treat diabetes, it goes to endocrine, and celiac disease, which is a stomach disorder or a gut disorder, goes to GI. In our hands, our patients with lupus, about 10% of them will have thyroid disease, autoimmune thyroid disease. So that's something that we look for as well. Patients with lupus can also have Sjogren's syndrome, another autoimmune disease. So yes, autoimmune diseases can cluster.
I know the symptoms are very complex and sometimes they overlap. What are the ways you diagnose a patient through, I know you have a physical exam, what kind of tests you do? Like blood work or...
Yeah, so really a diagnosis. We have in pediatric rheumatology now, we have sets of standardized criteria that will diagnose most of our diseases. So if we use lupus as an example, right now we use the American College of Rheumatology, or ACR, criteria from a few years back, and this is essentially a set of 11 criteria, and we need to see 4 out of those to diagnose lupus. And these criteria include both laboratory features and physical findings as well. And other diseases that we see similarly have sets of criteria.
One part of the project I've been struggling on is the pathogenesis of it, why and how it happens. Do you professionals have a theory on why it happens? I know it's very complex, but
why what happens?
Why the body attacks itself?
Well, there are theories. There are volumes written on pathogenesis or the cause of these diseases. It's still not fully worked out, but for a disease like lupus, for example, there seems to be a loss of tolerance, so that we're no longer tolerating self-antigens, and now these become foreign antigens or foreign proteins. So the body then will attack these self-antigens because of that loss of tolerance. There are multiple mechanisms. Like in lupus, it's a classic immune complex disease. What that means is that you have a substance, a protein, it may be some altered DNA molecule that you actually carry yourself, and that altered DNA is antigenic, that is, it stimulates the immune system, and it forms a complex with antibodies against the DNA, as well as complement components, which are part of the inflammatory response. So you have this typical antibody-antigen complement immune complex, which then circulates and is then deposited in the ventricles of the brain, the filtering system of the brain, the filtering system of the kidneys, the skin, and other organs. So that's another part of the disease pathogenesis, at least in lupus.
What is the goal of treatment? Is it's definitely more symptomatic versus curative?
Well, we'd love to have cures, and in most autoimmune diseases, we don't talk about cure yet. Although now in rheumatoid arthritis, we're talking much more about remission. That is, disease is quiet. We don't think it's cured yet, but with medication, we can get patients with rheumatoid arthritis into remission a lot more easily with some of the newer biologic drugs in the last dozen years. Lupus is a little trickier because we don't have the same degree of success treating lupus as we do rheumatoid arthritis.
In general, what is the prognosis for a patient in terms of life expectancy? Can they expect to live a normal?
Depends on which disease.
Can we say, how about lupus?
Lupus, the 10-year survival rate is probably about 87, maybe as much as 90%, 10-year survival. There are, some deaths after that, but that's much better than it used to be. There are very few deaths in rheumatoid arthritis. Some of the other, I'll give you an example of another rare autoimmune disease called Wegener's. I don't know if you've come across that at all. Does that sound familiar?
No.
So, Wegener's granulomatosis, big name, and actually it was just changed. They didn't like the name Wegener because it was named after a doctor, so now it's called GPA, granulomatosis and polyangiitis. And what that is, it's an autoimmune disease that causes inflammation of blood vessels. And typically these are blood vessels that affect the kidneys, the lungs, and the airway, the air passages. And before effective treatment, which was before 1980, the death rate or mortality rate was about 90% within 5 years. Now, with effective treatment, the mortality rate is about 10% in 5 years. So it's much improved. It was reversed.
Have you ever heard of Muckle syndrome?
Muckle-Wells?
Yeah, maybe Muckle-Wells. I have a cousin who was diagnosed with it. Apparently it's very, very rare.
Yeah, that is very rare.
Yeah. She lives in Ohio, and my mom always tells me how she complains about like brain pressure, and it's very sad, but she's getting treatment now. But yeah, she's wondering if she knew about it.
But you think it's Muckle-Wells?
I think they diagnosed it as, Muckle-Wells.
Right. Yeah, that's pretty uncommon. But now, actually, there's some very effective treatment for that, which is referred to as IL-1 inhibition, interleukin-1 inhibition, and there are 3 medications that all do that.
Do you think in your professional opinion, do you think the category of autoimmune diseases is underfunded and relatively unknown to the public? Are parents shocked that his or her child have an autoimmune disease?
Well, I think it's certainly underappreciated in pediatrics for sure, because these are still pretty uncommon diseases in pediatrics. So, for example, rheumatoid arthritis in kids, which is now officially called juvenile idiopathic arthritis. Idiopathic means we don't know the cause, JIA. Affects about 165,000 kids in the country. So it's not rare, but it's not common, and most people do not realize that. By the way, there was an interesting article in the New York Times 2 weeks ago in the magazine section. I don't know if you've seen it.
No, I haven't seen it.
Yeah, you should read that. It's a very, very interesting article about one mother's approach to her child who developed arthritis and how she used some alternative methods to treat that. If you want, if you write down your email address, I can send you that article.
Sure.
But anyway, you were asking about, knowledge or
Just funding.
or funding. I mean, every specialty feels like their specialty is underfunded.
Yeah.
Um, we certainly do in rheumatology, and so we're always fighting for more dollars from the federal government to NIH, National Institutes of Health, and that's where much of the research funding comes from. Yeah, I mean, basically is underfunded. The largest group of patients with arthritis is not autoimmune, and that's osteoarthritis, and that's more of a degenerative disease, breaking down of cartilage, etc., which we don't think is autoimmune. There are about some 40 plus million people. Well, actually, it's about 45 million people with that.
You might answer some career questions. How many years after undergrad school did the whole medical training and everything take?
Well, right now, after undergraduate school, so then you're doing 4 years of medical school, 3 years of pediatrics, and then 3 years of pediatric rheumatology.
Okay.
So that's basically it. What's that? That's 10 years after college.
What do you think it takes to become a good doctor besides being book smart?
You need good listening skills. You really want to listen to what your patients are telling you. We have a habit of cutting patients' stories short very quickly, not necessarily listening to them. So I think that's important. Being able to, synthesize or put things together, in pediatrics especially, all symptoms usually fit into one diagnosis. So sometime, with experience, you can kind of figure that out. If they're having stomach pain and rash and joint pain, well, then it must be this. But, now there are programs actually where you can plug in symptoms, or there are apps, and you can actually come up with a diagnosis.
If you could give one piece of advice someone wants to pursue a career as a doctor, what would it be?
Go for it.
Go for it.
Yeah, it's still a great field. There have been some restrictions on reimbursement, like from insurance companies or from the government. There's more paperwork. We're all going electronic. So there have been a few more, hoops to jump through. But in the end, it's still really about treating patients, and you're doing some good. And I have 2 adult kids and 1 in college, and the 2 adult kids, while they're doing decent work, it's not really, I don't think, relatively as useful. Maybe that's a judgment call, but
satisfied.
yeah, they may be satisfied with their jobs, but from a societal point of view, you're not really helping out humanity as much. And here, I think in medicine, you're making a decent living. At the same time, you're really helping people, or you're advancing knowledge or research or teaching. And within medicine, there are so many different paths to take. Once you have your MD degree, that you can always find the proper path to take.
That was my last question. Why did you choose rheumatology specifically?
Because that was sort of a not a last minute decision, but I had a teacher in medical school, my 3rd year medical school, when I was doing my required internal medicine rotation at the hospital. My teacher at that time was a rheumatologist. So he really became my mentor,